You're listening to Fast Facts, Ask the Expert with Tom Viola. Listeners, welcome back to another episode of Fast Facts, Ask the Expert with Tom Viola, talking about local anesthesia. Tom, thanks for being here again.
Thank you, Andrew. It's a pleasure working with you. You know, I love you, buddy.
I know it. All right, here we go. Listeners, look, sometimes I just run out of really great questions, and that's what I'm doing today. It's a little bit of a cop-out. I'm just going to admit it to it. But Tom, here's the thing. Like you've taught thousands, tens of thousands, hundreds of thousands probably by now. So many clinicians have heard you speak. At the end of all of your lectures, you spend a little time with them, which is very kind of you to do. People will stop you in the halls. They have all these questions. What is the most commonly asked question that you get that we haven't asked you yet? Yeah,
I think
right?
The most commonly asked question that I don't ordinarily talk about is whether or not to use epinephrine. Now, I know we've touched the subject briefly, you and I, in our past episodes, and we've kind of, worried about epinephrine, but it's one of the most commonly asked questions that I don't get a chance to necessarily address in my lectures because it encompasses a lot more ground than you think it does. The follow-up question, or the question 1A to that question, is, why did my patient get numb? What did I do wrong? And the answer really is the same for both question 1 and question 1A, which is, did you use epi? Now, I realize why we don't use epi. It's because maybe the medical doctor has said, no epinephrine for this patient. Or maybe the patient has said, look, I don't want epinephrine. I've used it before and I didn't like the feeling I got, so I don't want it. But in those two situations, you got to realize that there's some flawed thinking there. And that is that if you don't use epinephrine, the anesthesia is going to not be as profound and not going to last as long, which means the patient's going to end up in pain. And all you're going to do in that situation after 40 minutes, realizing that the procedure is far from over, is have to give them yet another injection. Okay, so the patient experiences what I call breakthrough pain. What does that mean? Well, they were completely and profoundly anesthetized and now they feel pain. What does that mean? A surge of what? Endogenous epinephrine, which we know we're commonly referred to as adrenaline. Okay, so then you say, oh, you felt that? Great, let me give you some more anesthesia, because that's what our gut tells us, right? When it fails, give more. So we give them more anesthesia. And of course, now in their mind, they get another injection. That's painful. And now they're waiting for that to wear off because the first one wore off. So that's even more endogenous epinephrine. So in essence, the patient's getting more endogenous epinephrine than they're getting exogenous epinephrine. And that's what I've always said to my audiences. You can always control the amount of exogenous epinephrine you give a patient. You cannot control the amount of endogenous epinephrine they're going to produce in response to the pain. So if you want to know why your patient didn't get numb, realize that if you usually don't use epi, you're not going to get the results you're looking for. But here's the part I never get to talk about, Andrew. Why? Why does epinephrine make anesthesia more profound? And why does epinephrine make anesthesia last longer? And that's the biology behind this, okay? Basically, every anesthetic agent that we use is a vasodilator. So when you inject the anesthetic solution into the tissue, all of the blood vessels surrounding the injection site dilate and pop open. What does that mean to the clinician? One, your anesthesia drains from the injection site more quickly, and therefore there's less duration of action, right, and less efficacy. And number two, what fills the hole because of the vasodilation is blood. None of those things we like in dentistry, right? None of that works for us. So the reason why epinephrine works so well is because it is a vasoconstrictor in mucosa. Okay, so now you're counteracting the vasodilative effect of the anesthetic agent with the epinephrine, which now provides vasoconstriction, locks the anesthetic agent in place so it can't drain out, keeps the blood out because blood can't penetrate the tissue since it's vasoconstricted. And that's a win-win for dentistry. But here's the other part about epinephrine. Got to be careful. Accuracy and technique matter. Why? Because while we always commonly refer to epinephrine as a vasoconstrictor, if you were to inadvertently inject epinephrine into skeletal muscle, which is very possible with, let's say, a mandibular block or something like that, you could easily penetrate the muscle with the tip of the needle If you inject epinephrine into skeletal muscle, it has the opposite effect. It acts as a vasodilator. And that means people are likely to get things like trismus, hematoma. So I see why, if you've ever had that happen to a patient, I'm not using epinephrine anymore. But you're sort of giving up, the ship a little too early, because really the torpedo hasn't hit the side yet, okay? Work on honing your accuracy and technique and realizing that epinephrine is not your enemy, it's your friend. And even though medical doctors insist on, don't use epinephrine in this patient, if they realize that the epinephrine you're using is actually 1 to 100,000 dilution, not the 1 to 1,000 dilution they're used to seeing in medical settings, and they realize that you were using that to produce vasoconstriction and prolong the duration of action of the anesthetic so the patient would produce less endogenous epinephrine, then they would probably agree to the use. Even the patient would probably agree to the use if, again, with your technique, you learn to inject a little more slowly. That does go a long way in preventing some of the beta-1 receptor activity, which is that tachycardia, palpitation, nervous feeling patients get from epinephrine. And realize also that while epinephrine can cause bleeding, as I said, based on injecting in into skeletal muscle, overall, almost every person could tolerate epinephrine except one patient. And that's the patient with a sulfite allergy. Every anesthetic agent solution that we use that contains epinephrine contains sulfites as an antioxidant or preservative, depending on how you refer to it. And those are the only people that I would not use epinephrine. But almost everybody else, unless you've got, unless there's a real reason not to use it, epinephrine is probably more of a friend than a foe.
Tom, you are one of the most brilliant people in this whole entire industry. We're so lucky to have you. So thanks for being here. Awesome content as always. If someone wanted to reach out to you, how can they find you?
They can find me anywhere on social media at Pharmacology Declassified and on my website at tomviola.com.
Absolutely. Okay. Thanks, Tom.
Thank you, buddy.
Thank you for listening to Fast Facts Ask the Expert. If you have a topic you'd like one of our experts to answer, simply email me, Andrew at ataleoftwohygienist.com, and we will get it on the air as soon as possible. Thanks for listening.